Welcome everyone. Really excited to be here with you for this Crisis Jam. My name is Dr. Aisha Zalani Brumsey. I'm the Director of the Behavioral Health Division at the Council of State Governments Justice Center. And we have a really great agenda, like I was talking about earlier, if you were in the pre-call, but we have a fantastic agenda for you today, including a featured presentation from Tony Sanchez, who's a peer specialist with Faces and Voices of Recovery. So just as a reminder of the incredible work that we are all engaged in here, this Crisis Jam includes over 61 organizations, people internationally and nationally, and really is just, this is just shows you the kind of breadth of interest and expertise that is in this room as we're all learning together and helping to support and improve crisis systems. Next slide. And also just a reminder, as always, you can go to talk.crisisnow.com site for the Zoom link, for the materials from previous sessions, as well as to see what the next session is going to be. And also, of course, all of the articles and featured resources. So this is just an incredible resource, particularly if you miss a session, you can go back and watch a previous session. This is the featured, one of the featured articles for today. And it is I think we're all acutely aware of the youth mental health crisis that we're experiencing right now. But this is a really tragic description of the lack of access to psychiatric care and with youth having to spend time in emergency rooms. And so this is just a good reminder of why we're all in this room and doing this work. And you can see the link to this article, both I think they'll put it in the chat, but as well on the talk.crisisnow website. And so a helpful reminder of the reason we need to also focus on making sure that we're expanding access to youth and youth who are in crisis. So the quote from today comes from NAMI's Reimagining Crisis Response Initiative, where NAMI's really been pulling together a set of principles that a number of organizations, individuals, and many people are getting on board with around how to improve crisis services. And this one's really apropos for the day because it focuses on the importance of peer support. So I'll just read it shortly. So incorporates the unique and essential role of peers and their families in all aspects of providing crisis services, from creating a crisis system that meets the needs of the local community to including peer support workers as part of the continuum of care. And I just love this quote, both because it is going to set up our featured presentation, but because it talks about the essential nature of having people with their own lived experience to be at the forefront of providing care and support for others who themselves experience crisis and how important that is. And so I just want to thank NAMI and the Reimagining Crisis people for that quote. Okay, and so now what I'd like to do is bring up our featured presentation. And if I could ask Tony Sanchez, I'm going to introduce you really quickly, your peer support recovery specialist from Faces and Voices of Recovery. And I know that what you're going to be talking about is not only just the importance of including peers in this work, but how you have been working with the state of Georgia to really help them understand that there are barriers to allowing peers to do this work. And if we want peers in crisis systems and in mental health and behavioral health systems, we have to remove those employment barriers, both because we want to, if we're going to walk the walk on helping people in recovery, they need to be able to have jobs and do this work, but also because we're leaving tons of talent on the table if people who themselves have experienced behavioral health needs aren't able to come forward and support others because we're putting in place barriers. So I'm really excited to hear about the work that you've been doing in Georgia and the way other states can learn from that. So thank you for the work, and can I turn it to you?
Thank you, Aisha. Thank you for that, for those really be myself cool words. And I want to welcome everyone, who's on the call. Real briefly, I just want to say that I'm not here to preach or to lecture on what should be done. I just want to share a little bit about my lived experience, right? And some of the work that I've been involved that allow us to make some changes, what work, what could we do better, and how do we continue to move forward in providing opportunities so that people can live their best lives. Next slide, please. So, so traditionally, when given an introduction, we talk about those major professional educational highlights, right? But what you're seeing here is how I really identify myself, right? My name is Tony Sanchez, and I'm a person in long-term recovery. And what that means to me, that it's been over 20 years since I've had a challenge with drugs, right? Including alcohol. And because of that, I live this amazing life. I'm a grandfather, I'm a son, but I do see myself as a black, but I see myself as a black male in America. I'm also a Puerto Rican from the Bronx. And there's other things that I identify as, but those are the things that I really are core to who I am, not just the professional things that I've done. Next slide. And so this is, how the world can perceive me. So today, so just, to add to the previous slide, I'm the current director for partnerships at Faces and Voices of Recovery and the training team. I'm the former director for the Office of Recovery Transformation at the Department of Behavioral Health and Developmental Disabilities in Georgia. I'm the co-founder and the former executive director of People Living in Recovery, a recovery community organization in Athens, Georgia. However, even with all of that, right, I could still be seen just as a black man or a convicted felon, right? Because that's part of my history, a drug addict, because of my previous challenges with substance use disorder and not having any formal education, not being a college graduate. So sometimes even those labels can be limit the way that I'm perceived, I'm perceived with limitations, right? Next slide. And so why is this important, right? So, the system makes me believe, or wants me to believe, or makes the majority believe that once you're found guilty and you serve your time, that you can re-enter society and put that behind you, right? But in my experience, after I was released, so when I was released from prison, it was really, really hard for me to re-enter, right? It was really hard for me to
Would you mind tossing this for me? It was just blowing.
Sorry, Tony, I think you're muted.
Thank you, Aisha. What I was saying is that, although after I served my time, right? I was under the belief, or the system wants us to believe that you can serve your time and re-enter society, and that's not necessarily true. There were so many different barriers, and one of the things that stuck out was the fact that I was a convicted felon. So there was numerous attempts to find employment. There was numerous rejection, right? There was, and because of that, I started to internalize the same beliefs that were perpetrated, by society, that once a criminal, always a criminal, or that I would never be able to get ahead. And that led a lot of times for me to go back to using drugs, and what it turned into was a vicious cycle. You know what I'm saying? That perpetuated year after year. I've actually used drugs for over 20 years, and I have over 20 years of recovery. So 40 years of lived experience through it all, but it wasn't easy. So I was kind of like, and let me settle down. I'm a little nervous, right? But I wanted to paint a picture of what what it should be like, you know what I mean? What, ideally, you should be able to return to society, but in my experience, how difficult it really was, right? But one thing that I learned is that I have a voice, right? And then through my lived experience, that I do have some information that is very useful, right? So I want to take some time to talk a little bit about how I became involved in creating a policy in the state of Georgia for people with a criminal background. As I mentioned, I struggled a lot with finding a job, and I was often turned away from the good paying jobs when they learned about my criminal record. After working for an agency in Georgia, I suddenly became ineligible for my position due to a new state policy that was put in place. I knew that I didn't want to be silenced or live in fear that my position would be taken away from me and I would no longer be able to provide for my family, right? So because of that, right, the fear of not knowing what's going to happen, like the fear of not knowing what was going to happen next, you know what I'm saying? Like just I just motivated me to talk about what the how yeah, I mean, it just, there wasn't any alignment, right? You know what I mean? There wasn't, the way that we were talking about recovery and that we should become productive members of society, or that we create these they didn't align with what actually was going on, if that makes sense. Next slide, please. So, when I was working for this agency, and it was a community service board in Athens, the policy changed, right? And at that time, there was an opportunity, there was an opening at the Department of Behavioral Health and Developmental Disabilities, right? And a friend of mine continued to nudge me to apply for the position, and I was like, I don't want to do that, right? But when I got the letter, right, from the current position that I was in, that I had became ineligible, I applied for the position at the Department of Behavioral Health, and they granted me an interview. And I said to myself, man, the left hand doesn't know what the right hand is doing. So when I went to the interview, I accepted the interview, but it wasn't to get the job, right? It was to tell them, or to explain to them, how their policies were actually creating more stigma and demoralizing individuals. You know what I'm saying? At that time, I had 14 years of continuous recovery. I was doing amazing things in my community, but I was still being held accountable for something that happened 15, 18 years ago. You know what I'm saying? And the other part was that they were spending so much money in certifying peers, but then peers weren't able to find employment. And it just did not make sense to me. You know what I'm saying? That, that you say you believe in recovery, I mean, but your practices doesn't really say that, right? You know what I mean? That, and so this was an opportunity to dismantle stigma, you know what I mean? And what happened was, that I got the job. So next slide, please. And so after being hired, I wanted to use my platform to seek real change, right? You know what I mean? I wanted to be a part of creating a place where individuals should, were given an opportunity to tell their story. There's quantitative data, but we should always mix that with qualitative data too. You know what I mean? That's why I gave a little history of who I am, so that, because if you see me, like if you was to see me, or like even now, the way that I'm dressed, or where I work at now, you wouldn't know that there was a time when I was homeless, where I lived better in prisons and institutions, where I thought, that I was gonna either die in the streets, or because of the drug use, that was the fate that I was that was left for me, you know what I'm saying? But recovery changed all of that. And there is so much value that not only that I can bring, but the other 23 million people that are in recovery could bring to our country. Right? Next slide. So the new policy Well, let me back it up, right? So, because I don't want to give the impression that this was just me. This came from the governor's office in 2015. Governor Deal, he put out an executive order to all government entities in the state, encouraging them to implement a hiring policy intended to encourage the full participation of motivated and qualified individuals. And with that, you know what I mean, we in 2017, 2018, you know, we formulated, we got a group together and we created a policy that prohibited the use of criminal record as an automatic bar to employment. We, you know, prevent the use of an application form that inappropriately excluded individuals. So, you know, we banned the box. So just because someone checked that they were, we didn't even ask that question. You know what I mean? But if they did, if somebody divulged that they were had interactions with the criminal justice system, it didn't automatically bar them from an interview. Next slide, please. So because of that, right, we formed a committee, right, and that reviewed applicants, right? So all individual applicants are required to have a fingerprint-based criminal history record check completed. So that's standard, right? And if somebody, and all applicants are notified, however rejected applicants, like, so everyone is notified, and if you're rejected, right, you get a letter saying that you're ineligible, and if you are determined ineligible, then you may request an individual assessment, right? And then that, so in that individual assessment, the person, you know, will talk about, we'll ask them to, we ask them to write a letter about, you know, about that spoke in depth about their crime, right? You know what I mean? But also we wanted to hear what they were doing about their recovery, right? You know what I mean? We wanted to know any certifications. We wanted to know how they were contributing into their community, how they became productive members of society. And those are the things that that would allow us to determine if individuals were eligible or ineligible. Next slide, please. So in 2019, right, we reviewed 141 individuals and 96 were deemed, and out of the 141, these are 141 individuals that received a letter that they were ineligible. And after the review, after we reviewed each individual person's file, 96 of those ineligible decisions were overturned, you know, and we still, you know, we have to do our due diligence. So not everyone made it through, you know what I'm saying, but almost 100 individuals were able to seek employment, you know what I'm saying, and we were able to get that it's not even raw talent, that amazing talent and lived experience that allowed us to serve our behavioral health, you know, or support our behavioral health service delivery system, if that makes sense, right? And so, next slide. Let me just try to bring it up and wrap it up in this one slide, right? So why is this important, right? Why do we need to be talking about changing policies that allow individuals with lived experience, not just with substance use or mental health challenges, but also with the criminal justice system to become gainfully employed? First and foremost, it's because it says that we believe in recovery, right? That people do get better. That once an addict, not always an addict, once a criminal, not always a criminal. That once, just because I may be living with mental health challenges doesn't mean that I don't have something positive to contribute, right? You know what I mean? We talk about Maslow's hierarchy of needs, you know, self-actualization. How do we help individuals get to that, right? And employment, right, for me, and being able to take care of my family was paramount. It was paramount. But if we're talking about this rollout, right, that's going to take place on July 16th, and we're talking about that, and I took the slide. Let me just give credit where credit is due. I took the slide from Georgia, right? But that Everyone needs someone to talk to, that you can dial 988 and you can get someone to talk to, right? And if you're in crisis, you can get someone to respond. And if you, and that there will be somewhere to go for everyone, then we need individuals to be able to fulfill that need, because that is a heavy lift. And what we're talking about is moving from a crisis-driven system to a more recovery-focused system, and which truly speaks to a recovery-oriented system of care, because it takes all of us to make this happen. This is a big deal. This is huge, right? Because I remember in times when I was in crisis, I had to get arrested to get help. You know what I'm saying? And what we're saying is that we don't no longer believe in that model, right? And that we are creating opportunities, right? And there's parity in some ways, so that people with behavioral health challenges can actually get the help that they need, right? And in order to do that, we're going to have to be able to fill those spaces. We're gonna need the voice of lived experience, people who have actually been there to help ease that burden, not to take the place of clinicians, psychiatrists, psychologists, but to enhance the delivery system that we are really trying to create. And with that, I thank you.
Tony, thank you so much. Really appreciate you bringing your full self, your wisdom to this work. And I can certainly say that not only did you get the job, but hundreds, thousands of people must be so grateful that you got that job, because you were able to help open the door for many people behind you to go to start working in the recovery space and to build a model that other states can capitalize on, how they can remove those barriers. So thank you so much for sharing that. I'm now just going to call up the incomparable Tanja Miles and Dr. Matthew Goldman to reflect on what you just heard. Thank you both for being here.
Thank you so much. Wow, this is a great conversation. Look, some of the most honest and the best peers I know who have with lived experience have also had lived experience in the criminal justice system. Why you say I said some of the most honest people I know? Because they made mistakes just like a lot of us. Unfortunately, I didn't get caught with mine, but a lot of them did. And so the fact that they're able to talk to someone who has been in the same space as they have just makes a whole lot of difference. Some of them know how to navigate through the system on the outside even better when they come out. I'm so excited that here in Louisiana, we're getting legislation passed that we'll be able to ban that box, so to speak, to make it easier for peers who do have, something on their record to still be able to get gainful employment and do the good work that they need, that they were created and they were called to do. Right now, as I speak, I'm in City Parish downtown with probably about 75 law enforcement agencies who know that peers rock, because we're the ones who are leading this meeting right now with the DA and so many other people. But one of the things they realize too is that they cannot law enforcement their way out when a person is having a crisis. So when you now have someone who's a peer with that lived experience, who's now a role model, who's doing good things in the community, they shouldn't be penalized for something that they did many years ago. And now, they paid their debt to society, they're in recovery, they're doing this good work. So to hear their voices, when their voices is at the table, because a lot of the guests and people that we serve do have those records. And we're not going to talk about junked up, drug charges. That's a story for another day. But I'm just grateful we're having this conversation. I'm grateful that we're doing something about it in Louisiana and across the country, because those peers, just like the rest of us, need a chance and shouldn't be penalized or punished for things that we did that we're now not doing anymore. And we're walking in our purpose.
Thank you so much, Ms. Miles. Dr. Goldman.
Yeah, just to add on those comments. So first, thank you, Tony. What an awesome presentation, and really appreciate your sharing your story. A couple reflections on what you described. So first of all, more from like a sort of understanding the broader context of how this plays in, what you were highlighting about structural barriers for people with lived experience to be able to enter into this key workforce, things like exclusion based on history of criminal carceral involvement. That's extremely problematic, because we know that people with serious mental illness are way overrepresented in criminal legal settings. We know, of course, that BIPOC people are way overrepresented in criminal justice settings. And that therefore means that if we're having that be a criterion for exclusion to be able to enter into this workforce, where we are so in need of representation, both people with lived experience and also racial, ethnic representation in these groups, that's really a structural problem. And so I think, the way to undo those structures, dismantle those structures, is through policy change, exactly as you described. So I just really want to acknowledge how important and how wise it is what you described, that you got to look at the underlying policies in order to undo these disparities. The other thing that I just wanted to comment on is, in San Francisco, we're fortunate to have peers involved in a couple really important programs. And just to highlight how valuable our peer workforce is in San Francisco. So we have a street crisis response team. This is a 911 dispatched co-responder team with a paramedic, a behavioral health clinician, and a peer. And in this team, it's often the peer who makes first contact with somebody who is in crisis. It's just like almost routine that the peer is so much, is going to be best positioned to make that initial connection and try to understand where somebody's at and try to build that rapport in what can, of course, be a very intense and heightened kind of environment. Another program that we've recently launched in San Francisco is a response to the drug overdose crisis that's happening in the Tenderloin neighborhood in San Francisco. And one of our key partners in this work is our adult probation. And you might wonder, why is adult probation involved in a drug overdose response emergency? And one of the reasons for that is because they have really important re-entry and employment programs that are under the auspices of adult probation itself. And they have created a pipeline to employment for a lot of people who are exiting incarceration. And some of the employers that most often engage with this program are service navigator and peer kind of programs, where the lived experience that those folks bring to the work is so valuable. So just a couple examples of how really important this can be on the ground as well.
Thank you so much, Dr. Goldman. Thank you both for those reflections and for putting that additional context on Tony's words and experience. I also see that we have Wendy White Tigering from the Georgia Behavioral Health Department, the Georgia Department of Behavioral Health and Developmental Disabilities. And Wendy, if you're on, we spoke about Georgia. Do you want to say a couple words?
Hi, everyone. Thanks for the tag. Yeah, Tony and I have had so many rich conversations about this, but I think the thing that I wanted to articulate is that often in haste, there are some federal regulations or some new federal law, and people will go, oh, we got to put this into place. And it has sweeping impact when it is not considered from all places in which it rests. And like, as a social worker, I can't say more about that, right? It's all context. And so for me, that's like an eye roll in a really global way when that occurs. But there were pathways for peers to work. We just had to hunker down. We needed lawyers who were supportive and recovery oriented. We needed, like leadership, like myself, like I'm an ally and an administrator in Georgia who really believed in the peer movement, and a lot of people to kind of sit down and do that real discernment. And it just, again, I just put in the chat that it is just a pause, I think, for all of us as administrators to really just consider all the recovery pathways. And every time you're implementing something, be mindful about how we really lift up this workforce and create those pathways. So that's all I wanted to chime in on. And that we miss Tony in his role in Georgia, although we've pulled him into some 988 work groups for which we're blessed. So it's good to see you all, and thanks for the tag.
Absolutely. Thank you for adding that perspective. That's right on point. And Tony, just as we move to the next section, I just want to make sure you're looking at the chat, because I think you're seeing how much what you just said resonated with everyone. So now we have the crisis trivia hot seat. Megan, I'm going to call you up. because this is you're on the hot seat.
It's
Don't
hot.
be nervous.
Let's see.
It's
Okay.
hot. It's hot, but don't be nervous. You're gonna get help from the audience. This is gonna be great. Okay, y'all. So here's the trivia. SAMHSA has published logo guidelines with clean geometry and typographic design that provides balance, sensitivity, and strength, highlighting 988 and Lifeline Project Hope. So which of the following is not one of the horizontal brands authorized for use by SAMHSA?
Let's see. Okay, I've seen the navy blue one before. I know I've seen the white one. Gosh, I'm not sure that I've seen the green one. Let's see. I think,
And we can get, Megan, if you want, we can see what the audience says first.
Yes.
And
Yeah.
then we can go for you're also welcome to call a friend as well. So let's see what the audience says.
Yeah.
All right.
I'm definitely going to go with the audience. I've never seen that green one before. Yeah.
Okay, so Megan's going with the wisdom of the audience. What is the answer? That is correct. The approved color schemes are black, blue, navy blue, and slate, and they are in both English and Spanish. So Megan, the hot seat was hot, but it wasn't that hot. You made it.
Thank you.
Thank you so much. All right. So now, Dr. McKeon, I think you're on to give us the SAMHSA update.
Yes, absolutely. Thank you so much. I appreciate the opportunity to speak with you today. Obviously, SAMHSA continues to be engaged in a broad range of activities to support the rollout of 988 as we get closer to the July 16th universal accessibility of 988 across the country. So I'll just mention a couple of things. SAMHSA has created a 988 workforce opportunities webpage with links to job sites for crisis services in the Lifeline network. And I will put the link to that into the chat. Obviously, one key issue in terms of building capacity across the Lifeline network has been funding, and SAMHSA's worked diligently on that, including the $282 million this year and the president's proposed $696 million budget, which I would just underscore is 100 times greater than the $7 million appropriation for the Lifeline just 4 short years ago, before the advent of the conversations around 988 and the 3-digit number. Over the coming days, HHS will be promoting the site throughout the mental health community and beyond, because in addition to the essential, for funding being essential, there needs to be the actual people. And we know it's a challenging environment for many in terms of building the workforce. So this is an effort to try to contribute to that. And we ask for your help in the effort by considering, posting on your social media, sharing in your listservs, or in any event supporting Mental Health Awareness Month to include links to this job sites for crisis centers. In addition, we are just under 2 weeks away from the May 24th FCC convening on geolocation for 988. It will be live streamed, so everyone can look at that. We are not anticipating that there will be a definitive outcome. In other words, we don't anticipate that at the end of the day, 988 will have geolocation. But what we are hoping is for some important ways forward as we look to balancing the incredibly important needs for geolocation, the concerns about privacy, and finding the best way forward that will save the greatest number of lives. So I will stop there. Appreciate the chance to speak to everyone today.
Thank you, Dr. McKeon. Thanks for giving us the update, and looking forward to seeing that website getting more promotion, and thanks for the update on the expanding federal support. So now what I'd like to do is turn to the data corner. I have Dr. Lisa Culp with me from NIMH. Dr. Culp, I'll turn it to you.
Oh, thanks so much. I'm so glad to be here to talk with you again. I gave you an update a couple of weeks ago, but now I'm featured on the data corner. I'm feeling pretty happy. So I'm Lisa Culp. I'm a psychologist and psychiatric epidemiologist, and I work with the suicide prevention research team at NIMH. This is just a slide that kind of is highlighting the priorities that we have, which is to look at quality improvement efforts for all things suicide prevention. And let it be known, we regard the Lifeline and now 988 to be a suicide prevention tool. And we would like to build more research around the utility of the implementation of interventions that go after the calls themselves. So this is what's been published recently by our NIMH director, and deputy director, and our team lead, Jane Pearson. Next slide. So we fully embrace the learning healthcare approach to things, which is to provide the best care. It's a feedback loop, measure your results, improve your services, look at how things vary, launch new research, and provide the best care. And it's based on an Institute of Medicine report that was published in 2013. And we have some really good experience at how this has worked. And next slide. So we know that it promotes a rapid science to service translation. It emphasizes standardized assessment, which is that measuring results thing that is so important to this. So we aren't looking at apples and oranges. It looks at variation in implementation, because any program that has boots on the ground, they have a little bit of a different approach just because of where they are, or the circumstances that they have to deal with. So we want to be able to understand what those kinds of changes or differences, how they impact the outcomes that are of the community. And then we also know that it provides a huge data source that allow us to look at the quality, the equity, different practice-based research, and evidence-based policy-making approaches that are available. Next slide. So in service of facilitating this learning healthcare approach, we have a lot of funding opportunities out on the street at this point that will, and this is a busy slide, it's meant more of a reference page for those who want to come back to it later. We talked about, I think Matt promoted that we had this nosy for crisis response services out on the street a few weeks ago, or maybe a couple months ago, but all of these others are listed because they promote research in various areas that go along that continuum. And a couple of weeks ago, we mentioned that there was an opportunity to participate in a meet and greet, and we had such a great response to that. Over 500 researchers and CCBHC leaders and others participated in that, and so we feel like that was a big hit, bigger than expected. Maybe the facilitators said we broke Zoom, so apologies if there was any quirks or mishaps that anybody experienced who might have participated in that, but we really hope that some relationships will be built from those discussions on that at that meet and greet. Okay, I think All right, I think it's over to Matt. And honestly, all of those research FOAs and everything, they have a contact person. Reach out to that person, reach out to me if you're interested in doing research or wanting to meet somebody who might, somebody in academia who might be interested in working with you on any research project you have. So, okay, over to you, Matt.
Thank you so much, Lisa, for joining this week's this month's Data Corner, I guess. Just wanted to follow up with a couple additional research resources, Data Corner bites, as we call them, a couple publications that recently came out in the journal World Psychiatry, which is the academic journal in our field that has the highest impact factor, has a really wide readership. And Sonia Johnson and colleagues from the UK published a really important review of the literature on acute psychiatric care. And one of the main points of this review is highlighting the need for additional work in the crisis services research space. So I'll put the link to that article in the chat. Another thing to highlight is in this edition of World Psychiatry, that featured publication from Dr. Johnson is part of a forum. And so there were a series of additional commentaries by other authors responding to her article. And myself and Dr. Sarah Vinson wrote a response to her article titled Centering Equity in Mental Health Crisis Services, really highlighting the importance of collecting data on things like race, ethnicity. I think I also saw in the chat a mention of SOGI, so sexual orientation, gender identity type data, really the importance of capturing those kinds of data and doing analyses on them in order to better understand disparities, in order to then be able to address them and resolve them. So I'll put that link to the chat. And then the last piece here is the NIMH, in addition to the many opportunities that Lisa described today, has their annual conference on mental health services research coming up in early August. And they are accepting submissions until May 15th. So that's just the end of this week. And one of the topics of interest for this conference is suicide prevention and crisis care. And this is a very high priority, high profile conference that NIMH puts together. And so just want to encourage submissions from the crisis research front to make sure that this important work is well represented in that setting. So thanks so much for your interest in Data Corner, and I'll hand it back to Aisha.
Thank you so much, Matthew, and thank you, Lisa, for that and for outlining some of the resources that are available and for highlighting those publications. That sounds great, and we'll definitely be taking a look at those. So now what I'd like to do is call up Stephanie Hepburn to talk about the most recent crisis talk and interview the featured speaker.
Thank you, Aisha. Yeah, so this week I spoke with Whitney Bunce, and she is a youth policy analyst at CLASP. Whitney, if you're on the call, you mentioned that many schools have a police presence, but don't have in-school mental health services. Can you share a little bit about how youth mobile response services actually help to fill in the gap?
Hi, can you hear me?
Yeah, I can hear you.
Awesome. Right now there's about 14 million students, or back in like 2017 when ACLU did this report, they found that over 14 million students were walking around with police officers, but no counselors, no social workers, no school psychologists. And so that's a problem. And we understand that there's a workforce shortage that is happening in the mental health space, but there's also one happening in schools and education. And many mobile response teams are looking for ways, or some mobile response teams are looking for ways to fill those gaps in schools. And one way is by partnering with mobile response teams to eliminate the use of police officers in schools as their mental health supports, but also to eliminate police in schools to stop the criminalization of Black and Brown students. This will be a way where, so one state that has done this in some ways is Connecticut. They looked at their raw data about their school to prison pipeline, and they started a school-based initiative, which is a diversion program where schools are able to call their mental health mobile response team, where if a student is experiencing a behavior issue or a mental health crisis, they're able to call their mobile response team, and they come on the scene and de-escalate and provide those services. They have seen in these schools that they're in a 40 to 100% reduction in kids being referred to law enforcement, suspension rates going down, and things of that nature. And so the mobile response teams have an opportunity to not only impact the mental health system, but many systems that young people are involved in, including the education system. And right now, a lot of schools are trying to figure out what to do with their ARP dollars. And one of those ways they can use that is by funding, help fund mobile response teams in their schools.
And you talked about COVID and how, youth mental health hasn't seemed to have been on the radar as much as it should be. Can you talk a little bit about the pivot that you took, the work that you were doing with the technical research initially, and the pivot that you took when COVID hit?
Yeah, I think, before COVID was happening, I was very invested in young adult mental health. We were doing some technical assistance work with Prince George's County and the state of Utah to really figure out how to make mental health supports more accessible, also developmentally appropriate. One of the biggest things that we've seen is these bridge and like these siloed systems where because we really focus on young people from the ages of, or like systems are focused on young people from the ages of 0 to 18, but understanding that young people brains don't fully develop until the age of 25. And so this age period between 16 and 25, there's really no services for them, and they often are pushed into adult systems. And so what we were doing for these two localities is trying to bridge that gap. And one way Prince George's County was trying to do that was through mobile crisis. And so we kind of looked at the funding streams that they were experiencing, figure out how their mobile response teams can be funded. And so I did some research on different ways that their mobile crisis team could be funded. But then that's when the pandemic happened, and really our team started to look at what was the mental health crisis like in America in general prior to the pandemic, which was really over 1 million young people had unmet mental health needs. And that now that's up to like 3 million or even more. And so, the president as well as the Surgeon General have come out and talked about the young adult, the youth mental health crises, but they're really associating this with social media, which is really a part of the problem, but it's not the root of the problem, and we need to address that as well.
Thank you so much for hopping on the call, Whitney. I'll send it back to you, Aisha.
Thank you so much,
Stephanie. And Whitney, I don't know if you're actually able to see the chat, but I just want to let you know that there are folks who are really validating what you had and what you spoke about and are resonating with the article. So thank you for your work. I'll now turn to the Nashville update. We've got Arlene on the phone. Arlene Stevenson, how are you?
Hey, fine. How are you?
Good. I'll turn it to you for the update.
Thank you. I wanted to highlight these 3 papers for you again. Last week, I think there were some people who missed how to get in touch to find them. And so I wanted to start with that first. You can find them at nashbid.org. That's spelled NASMHPD.org. And it's under What's New, 988 Resources. We've developed 3 documents here. The first has to do with legislation. And it talks about the opportunities to design a system that works for everybody and what the common themes are in the legislative bills that are out there now. Talks about correcting weaknesses in your current systems through legislation. It discusses some of the creativity that the states have exhibited in their bills. And it also talks about the importance of addressing call centers and the continuum of services in your bill. There are some things that address confusion for legislators, which they always seem to be confused, don't they? And also some available assistance from partners. And the paper ends with summaries of each of the state's bills through January of 22. Then their second document for you there is the FAQs. And the purpose of the FAQs was really to ratchet down the opposition to the phone bill, the phone fee bill. And the highlights of NAMI survey we used because they discuss public opinion issues about mental health and crisis services. And we know that's something that legislators care about. We talk about why 988 is better than 911 for crisis contacts and why the FCC wasn't able to provide a 911 number. What are the concerns of the telecom industry, and are they all in opposition? And then we end with a response to the naysayers using some quotes from the telecom industry providers who are supporters of 988. You have to read that. And it's really a great tool to leave in the legislator's office too. The third document is a paper on financing, and it discusses the planning process and your operational readiness for the Lifeline. Then it goes into the continuum of services and details some options for funding. We talk about Medicaid, which has a lot of options, phone bill fees, Medicare, philanthropy, insurance parity enforcement. And then we make some recommendations about finding new partners to help you in supporting your financing plans. Knowing who in your state has the real budget power. Is it your governor or your legislature? Because that influences your planning approach. Also, the importance of briefing the governor and the legislators so that they're prepared to answer questions when they get them. There is a benefit to making friends with your assistant attorney general and some folks in Medicaid. I know there's some policy geeks from Medicaid on this call, so we need your help. And the paper ends with a state-by-state summary with some insight into the state's creativity and how they're financing their systems, how they need to be sustainable and probably have multiple sources of funding. And again, you can find them on the nashville.org website under What's New 988 Resources. Thanks, Aisha.
Arlene, thank you so much. Those are fantastic resources, and I love the highlights on partnership, Medicaid. Also, I love that piece about having telecommunications talk about why they are supportive. It's so important to have sectors speak to each other about why they want to see these types of changes made. So thank you so much, and thanks for reminding us where we find those. I'm going to call up now, I think Sarah or Joanna to talk through some federal updates. Joanna, you're first.
Absolutely. Sarah is not here today, so I'm just going to launch into the updates that we had from last week and then combine them with this week. So as many of you know, we've been following the 988 and Parity Act, which is the sort of so-called skinny version of the 988 Implementation Act. That's going to be moving to a markup in the Health Subcommittee of Energy and Commerce soon. So we're looking forward to that, and we're trying to keep an eye on that. We know that they're working with committee staff to make some adjustments. So again, we're keeping an eye on that, and we'll update as we go. Additionally, for this week, actually right now, the House Energy and Commerce Committee, the Health Subcommittee again is marking up several bills, one of which is the reauthorization Restoring Hope for Mental Health and Wellbeing Act. That includes several suicide prevention 988 revisions. So that has the Garrett Lee Smith suicide prevention grants. And it does include some 988 crisis care provisions, including the Behavioral Health Crisis Coordinating Office and some provisions for continuum of care best practices. But again, we're going to keep an eye on that, see where that goes. We're expecting that to go to a full committee markup shortly after today's markup in the Health Subcommittee. And then we also saw the text come out of the Senate for the version, for their version of the reauthorization, and that's the Mental Health Reform Reauthorization Act. So again, we'll keep an eye on that. We've been told that the Senate Health Committee is working through those, and they'd like to wrap up all of that by July 4th. But again, we'll have to see how the ENC committee and Help can work together on that. And that's everything we have for now. But I will hand it back to Aisha. Thank you so much.
Thank you so much, Joanna. So next slide, I think we have NAMI coming up, and I believe Stephanie Pasternak, you're on the call to talk to us about this map and how you're looking at states, what states are doing to support 988 and the updates you're doing there.
Yeah, Aisha, thanks for giving me a couple minutes to talk about this. So I'm excited to announce that NAMI actually launched a new 988 comprehensive state legislation tracking map. And I actually just shared a link to that in the chat. This new tracker lives on our reimaginecrisis.org advocacy campaign website. And we decided to make some changes just to better reflect what is a really increasingly complex legislative landscape of bills that are impacting 988 implementation at the state level. And when you go to that website, what you still see is now an interactive map that tracks states' progress in enacting comprehensive implementation legislation as defined by some key provisions of Nashville's model bill, which means defining 988 crisis services, how they'll be funded in the long term, including that key provision with the telecom fee, and setting up system oversight. And any bill that kind of hits those three key points, we define as a comprehensive implementation measure. Bills that hit some of those points, but maybe not all, we describe as a partial implementation measure. And so that's in the two green colors versus the comprehensive, which are the gold and yellow colors. But we also know there's a lot of legislative activity happening outside of those implementation measures. You know, we got a lot of feedback about folks want to see appropriations bills, study bills. So following the map, you see a much longer chart now that actually details what's happening with investments of ARPA funds. And you can also see more qualitative information about what's happening in each bill. So this is a pretty new resource for us. There's my colleagues' contact information is on there, so welcome feedback and hope that this is useful for folks tracking state efforts. Also, just in case, just a couple new updates on what's most recently happened in a couple states. Connecticut has enacted a children's mental health omnibus bill, House Bill 5001, and a budget bill, House Bill 5506, both impacting 988. It looks like the budget bill will include more funding for mobile crisis teams and crisis stabilization units. And the children's mental health omnibus outlines some requirements for how 988 will operate. And one thing that's not legislation related, I just wanted to flag Nevada, which already enacted 988 implementation legislation, will have a regulatory hearing on Friday, May 20th about their 988 fee. They have a proposed regulation to charge their fee at their top amount at 35 cents. And folks can submit comments in support of that regulation. They're looking to drum up support for that. I'll post a link to that in the chat if you're in Nevada and you'd like to participate in that hearing.
Thank you so much, Stephanie, and for highlighting that resource. I know it will be really useful for us for the entire field as we move forward. And you're seeing a few, I just want to call your attention to a few comments in the chat responding to what you presented and some questions. Next slide, please. And so we have here just a few of the state cards. And then going forward, we have a little bit of time to talk through the calculator that you can find at calculator.crisisnow.com. And Paul Galdis, can I ask you to talk us through that a little bit?
Thanks, Aisha. Listen, I think one of the things I would say as a tip on the calculator is once you click in there and start looking at it, if you click on your state, let's say you clicked on any state, New Jersey or anywhere else, and you select a specific county, you can then work your way down, and many have been asking about mobile response team volume, time for response. And what you'll see the McKinsey team has done is they've actually mapped out the average time for transport in that county. You can change it. And once you adjust that number, if it says the average time is 20 minutes and you say it's 50 because of traffic and other things, then it will change the number of responses you would expect a team to do each day. So again, another way that you can get into the calculator, modify it based on what you see in your community to get the right projections.
And then I believe, if I'm correct, is it Tom Betlock would be able to speak to Moving America's Soul on Suicide? Tom happens to be on the call. Okay. Well, if not, then we've got just the last 30 seconds or so. I just want to let you all know, first, thank you all for being here today. Thank you to all of our presenters. This is a really rich discussion. If you have colleagues who want to watch us, they're not here, remind them that they can see the recordings posted on the website. We have Nancy Kirchner from CMS up next. So definitely make sure to tune in. She's been a big hit when she has been talking previously. And then the 988 Goes Live will be July 13th for a special edition of this Crisis Jam. So make sure to tune in for that as well. And once again, just thank you all for being here. Thank you all for the work that you are doing to support crisis systems and prepare for 988 and the entire crisis care continuum. Have a good rest of your Wednesday, everyone. Take care.